We're here today to talk about neuro-optometry, which is an emerging subspecialty of optometry. It's been around since the 1980s, and there's a convention for the Society of Brain Mapping that's hosting neuro-optometry, neuro-optometric rehabilitation, and neuromodulation as sessions at the large international conference. I'm here today with Shannon Mandel, who's a nurse, speaking about dysautonomia and how eyeglasses affect it. Dr. Robert Wilson, who's here to speak on post-traumatic stress disorder and how there's changes from brain injuries. He's an emergency medicine doctor. Dr. Patrick Quaid, who's an optometrist doing neuro-optometric rehabilitation in Canada. And this is Andrea Adams-Miller, who is talking about the biopsychosocial effects of a smile and the environmental changes that go on. Everybody thinks that eyeglasses are typically meant for eyesight and the outside of you, but they're not. The eyesight is only one small part of visual processing, which is an enormous category. And Patrick Quaid has a new book coming out called Learning to See, Seeing to Learn, due out in August, and I thought he could talk about his book.
Yeah, and I think the one of the premises of that book is we started our clinic mainly looking at children with problems when they're reading. So we wanted to look beyond the 20/20 on the eye chart. And what we started to find is a lot of these children, when you looked at their movements, the eye movements when they read were significantly abnormal, and yet a lot of these kids were still seeing perfectly on the eye chart. So we wanted to look way beyond what did you see on the eye chart. And when you look at your visual field, or how much peripheral vision that you take in, I mean, if I look straight ahead right now, I can still see you there, but you're blurry. My central part of my vision is clear, but we don't realize that the 20/20 in our central part of our vision actually only makes up a very small component of our visual field. It's actually about 6% of your visual field. About 94% of your visual field has nothing to do with the eye chart. So what we're trying to do in the book is try to get across to parents and to educators especially, that if a child struggles with reading, you need to look at their visual function beyond them seeing 20/20 on the eye chart. Over time, we started to notice that a lot of these children may also have histories of concussions. So some are developmentally based and some are concussions. So Dr. Singman at Johns Hopkins and I, so he's an MD Ph.D., I'm an optometry Ph.D., we decided to get on the same page and co-author a chapter in a neurology textbook. So it's called Neurosensory Disorders in Mild Traumatic Brain Injury. And chapter 16 in that book is on how vision impacts in concussion. And it was nice to see neuro-ophthalmology and neuro-optometry on the same page.
And concussions you see all the time as being a flight medicine surgeon, right?
Yes, I'm a ER doctor by trade, but a flight surgeon, retired flight surgeon with the Air Force, and working as a flight surgeon currently. We do use a lot of optometry in the field of flight medicine. My involvement is when I was working for the VA, worked with a lot of TBI patients and patients with PTSD, and then I was seeing probably 1 or 2 patients a week with TBI for an extended period of time, and I began researching, looking for possible solutions, and that's when I stumbled upon Dr. Zelinsky's practice through Dr. Clark Elliott's book, The Ghost Inside My Brain. And I felt like after reading that this was a possible solution to many of the servicemen I was trying to take care of, that would lead to the impasse that they all seem to reach. These patients with TBI reach a plateau after they've gone through all sorts of rehabilitative therapy where they just don't seem to get any better. And what's interesting is there was a study done in 2014 at the U.S. Naval Center in San Diego called the Marine Resiliency Study, where they looked at patients with mild, moderate, and severe TBI. And what's interesting is they found that 100% of those patients with moderate and severe TBI went on to develop PTSD. And so if we can treat the symptoms of TBI with the neuro-optometric techniques combined with neurocognitive therapy, and thereby reduce their symptoms of TBI, It is hoped, and I'm sure that we will find that the PTSD symptoms will also improve as well. Now, PTSD, of course, is also caused by traumatic experiences that the people oftentimes experience in combat, and that would be obviously a different source of the problem. But maybe in the future we could develop techniques to treat PTSD using neuro-optometric rehabilitation therapy.
Yeah. PTSD is interesting because, as you said, sometimes they have internal causes from concussions, and other times they have external causes from witnessing something where the visual input alters the patient.
Yeah, it's very interesting. For the patients that had moderate to severe TBI, according to that Marine Resiliency study, 100% went on to develop PTSD. And I can tell you in my practice, it seemed like almost every patient that I treated that had a significant TBI also had PTSD. But again, PTSD can be caused by multiple things, not only head injuries, but also terrible experiences can lead people to have symptoms of PTSD. And but I think that if we could make headway using the neuro-optometric rehabilitative therapy in the treatment of TBI, we will also make headway in the treatment of PTSD.
And I think that would be a great benefit to the veterans that have put their lives at danger, at risk for helping our country, and we could help them back. That would be incredible. That experience that they see from the Army and the Navy and anywhere in the military is an external visual input that creates these problems internally. And Andrea, you have background in other inputs that don't have bad repercussions.
Yeah, I do have some background in EEG and surface electromyography and biofeedback in general. And right now I'm the executive director of the Keep Smiling movement, along with the founder, Ken Rashan. And Ken started this movement where he was noticing and witnessing people who were amplifying goodness in the world. And as part of a connection with another man named Barry Shore, had these cards where they would have people hold these cards that say, "Keep smiling," and pass out this positivity and love to other people. So in these cards, Ken was taking these photographs of people and capturing them and then putting them together in books. And that's when I came in to the mix to create that more. So what we were noticing is two things. So the giver is giving the smile to other people. So creating, in fact, what is an environmental factor of a smile for someone else. And what we're reading in other research is that there may be long-term implications that a smile may actually, if it's conducted over and over again, both by the giver and the receiver, can have effects on repairing things that were previously thought irreparable, including PTSD or other things in conjunction with other things. I haven't seen anything that exclusively says only a smile, but in conjunction with other therapies and other modules in the world and models of health. So it's really exciting to see how this can make a difference in helping people really amplify better for themselves.
There's actually a lieutenant named Lieutenant Knoll, who's putting out a book for veterans on PTSD and alternative treatments to help them. And neuro-optometric rehabilitation is going to be one of the many treatments that's available. So, and Shannon, you had some other aspects to say about inputs and how.
Yes. Well, that makes me want to smile hearing that study. My daughter had a severe case of POTS. It's a form of dysautonomia that stands for postural orthostatic tachycardic syndrome. And it's a very hard diagnosis. It can be kind of a nightmare diagnosis. But I believe her POTS was caused by visual dysfunction. And it was quick and sudden when it hit her. All of a sudden, she couldn't walk more than 2 minutes without becoming weak and uncoordinated. And what I realized is she was, her hemodynamics, she had a lot of hemodynamic variability. And I looked for lots of answers and I wasn't getting any until I took her to Dr. Zelinsky. And Dr. Zelinsky was able to calm down her sympathetic nervous system to the point where her vitals are completely stable. And it actually has cured her dysautonomia and her POTS, which is pretty amazing.
So you're saying her blood pressure was raised and changed by the different glasses, but you had been to medical doctors before and other eye doctors also?
We had taken my daughter to an ophthalmologist, a neuro-ophthalmologist, a vision rehab specialist, and about 9 other medical doctors to get answers and treatment for my daughter. And none of it was working. But neuro-optometry did. It's pretty remarkable, actually. And it's pretty remarkable that there's a neuro-optometrist who has taken an interest in POTS, because that is a diagnosis that's understood by few medical professionals.
Oh. And I wrote a paper on POTS in 2012, so it was when nobody had heard of it. It's important. We have a campaign also to leave 2020 in the 20th century. The 2020 testing, as Patrick Quaid said, is archaic. When it was invented in 1862, it was a groundbreaking philosophy. It created a protocol for eye exams, and it made everything standardized. The size of the letters was all calculated to match with the clicks in the familiar machine. So 1 or 2 clicks would match with 1 or 2 lines of the chart. It was a groundbreaking, incredible discovery in the 1800s. But now we're in the 21st century, and it's not sufficient. The rise of autism, the rise of PTSD, the rise of psychiatric disorders, all which have a part in the peripheral eyesight, is crucial. As Patrick Quaid said, 94% of what's going in through your eyes is not being addressed when you do a regular eye exam. So it's time for eye exams to change. What we've done at the Mind Eye Institute is patented a test on linking eyes and ears. And when you put different glasses on people to alter their environment, their auditory environment is also altered. So people have some sort of relationship between the auditory and visual systems, and when you change the visual system, the brain changes the auditory system. So in schools, you have children who can listen to the teachers and who can see the teachers and watch them, but some of them cannot do it simultaneously. So all these children have their eyes checked and their ears checked before entering kindergarten, but nobody is checking, do their eyes and ears work as a team together? And about 22% of the people don't have their eyes and ears working together, and they get confused by the environment and go off into space, and you get attention deficit diagnoses and behavior problems and emotional reactions that are just a lack of skills of being able to use your eyes and ears as a team. So you know quite a bit about this.
Yeah, I think the problem always is that what we're seeing in the clinic and what's going on in the research, there's always a natural divide, and we have to. I mean, we published a paper in 2013 as optometrists in an ophthalmology journal to that point where we wanted to say reading depends on so many other factors other than 20/20 on the eye chart, and we published that in 2013, and we looked at 15 different metrics of eye teaming, and we found that if you took almost every metric outside of what you saw on the eye chart, they were almost very predictive of how the child would read. Now, there's other things that go into reading, like my phonetic awareness, do I understand sounds? But ultimately, when we read, we use a lot of eye movements. And for example, if you think about the word yacht and how it's spelled, Y-A-C-H-T, it's not spelled how it sounds. So when we look at that word, we associate a sound with that word because we've heard it. So in essence, we have to put a visual memory picture together with a sound, and we have to make the two jive, just like you said. So understanding the mechanics of both of those systems is really, really important. And over time, we started to realize that we actually see a lot of those symptoms in children with difficulty in the classroom, and we see a similar type of problem in post-concussion patients. Obviously, the symptoms are very different because one's very acute and one's more of a chronic thing, but the actual clinical findings are not that different in both of the populations.
You guys have mentioned, concussions multiple times, and recently we had an experience with the Keep Smiling movement with a woman who had a brain injury, and when she had first met Ken Rashawn, the founder, she was expressing about how difficult it was for her because the one thing she didn't have the ability to do was to smile back. So as she was being pushed in her wheelchair and she was in rehabilitation, people wouldn't smile at her and would avert their eyes away, and she was just craving for that attention attention and that expression of acknowledgement from other people. And she wanted to smile at them, knowing that that would give her that engagement, and it didn't happen. So that's another of that, when you think about the biology now that her whole body has changed and who she is, and then the psychology of feeling connected and loved and feeling important and loved and accepted, and then socially not fitting in because you can't smile. You guys are all addressing key factors of that, and I'm very impressed.
I wanted to add something on to what you were talking about with your daughter and the association of the head injury with the POTS. One of the things that happens that I see quite frequently in medicine is something called a vasovagal reaction. I'm sure everyone's heard of it. When you have blood drawn, the person sees the needle go in their arm and they become dizzy and pass out. And what happens is your blood pressure drops due to this emotional reaction to something happening to you. Well, a similar thing might be happening in TBI injuries, where the patients that I took care of would become very symptomatic all of a sudden. They'd either get a severe migraine, or they would get very vertiginous, or they get very dizzy, feel like they're going to fall over. And that alone might be something that would cause them to have a vasovagal reaction, and that would lead to the drop in blood pressure, potentially cause them to pass out.
Right.
That may be a partial explanation anyway.
Well, in my daughter's case, she POTS is defined as an increase in heart rate in 40 beats per minute from supine to standing in a pediatric patient. And you could take her heart rate and she'd be tacking away standing up. When we finally got some answers, a pediatric neurologist said, feel your daughter's pulse. And you could barely feel it. She was about 130 standing. And it explained a lot. You get neurochemical changes in your brain where you have anxiety, you get a total pain syndrome, you get severe migraines, visual changes. And Dr. Zelinsky was able to calm down her sympathetic nervous system through retinal neuromodulation.
What was her blood pressure doing when the pulse went way up? It was going down?
Well, POTS it's regardless of what your blood pressure does. It's a rise in heart rate regardless with a normotensive blood pressure. But she also had dysautonomia, so it was going, she had hypertensive times and she had hypotensive times.
And so how does that with the glasses then, that regulated out, is that correct?
One really interesting thing about the retina, and when you shine light on it, is that it's a piece of brain tissue. And just as not every piece of your brain is working at any given moment, not every piece of your retina is turned on at any given moment. So when you are depressed or something's going on in your body, your brain tends to either make the peripheral retina hyposensitive and kind of ignore it, or hypersensitive and be on red alert. Because that's what your peripheral retina is supposed to do. It's designed for protection while you navigate through space. So if we're walking and you see a curb, I will, if you and I are talking and we're walking along and there's a curb, I'll step down because the peripheral eyesight will see it and catch it and say, hey, there's some depth there, better step down.
And I think it's really important also to state that we know from the research that at least 40%, which is probably a very conservative estimate, at least 40% of the human brain is visual machinery. So it is absolutely your threat detection system. And we see in post-concussion patients a lot where they will have trouble navigating busy malls, grocery stores. And we always kind of joke in Canada and we say it's kind of the Costco effect. You walk into a mall and there's so much peripheral motion going on, the patient gets very overwhelmed, they're light sensitive, and you look at all those types of mechanisms, motion is mediated, motion and light modulation control is primarily mediated outside of the 6% that we use for the fovea for the eye chart. So it's really how well we can regulate the peripheral part of our visual system. So to understand that the eyes are the only part of the body that move, they're the only part of the brain that moves. It's really important to realize the optic nerve isn't like brain tissue, it is brain tissue.
But there's more to the peripheral retina than just the peripheral eyesight. They have studies now showing that the peripheral retina is directly connected with parts that are regulating posture centers, parts that are regulating your circadian rhythm. We even had patients talk about hunger changes and appetite changes because your hypothalamus is in charge of satiation when you feel full, and the retina is directly attached to that. They keep finding new retinal connections, and it's hopefully the next 50 years of my life will be spent studying all that and figuring out why and how. And sounds like 50 years of your life is going to be doing research on all of that.
No, I'm excited to hear about that too, because with the smiles, we've had some people say that when they're smiling, when they're happy, they're not hungry. When they're with other people, they feel better. We honor a lot of veterans, and with you talking about the PTSD and how they're overcoming with a social ability as well, I'm interested to know more about that even.
Well, obviously, I'm not a psychologist or a psychiatrist, but we treat PTSD in a variety of ways. We treat it with medications. We treat it with counseling, and I know that you all are now are treating it with neuro-optometric rehabilitation, and I think that all of these things, potentially can help. It's finding the right combination for each person, that really is what I think makes it work. So.
Now, in the book you were talking about that you're reading about the two minds and how PTSD is treated in anxiety and depression.
Yeah, and the book of Two Minds, the author basically makes a point that the brain is actually two brains, and you have the right brain and the left brain. And with patients that have PTSD, they oftentimes, one side of the brain will predominate. In some cases, it'll be the left brain, which is the logical side of the brain, will predominate. And in other cases, it'll be the right side of the brain, which is the big picture part of the brain, will dominate the feelings and emotions that the patient will have. And so what they do is they'll figure out which side seems to be causing the most reaction, the most symptoms of their PTSD, by basically having them put on glasses that block the right side of the brain, and then put on glasses that block the left side of the brain. And by doing that, they can determine, okay, in this particular patient, it's his left brain that's causing him to become emotionally upset and symptomatic. And so what they'll do is they'll make glasses which basically fade out the left side of the brain. And you do that by blocking the left lateral visual field and the right nasal visual field. And by partially blocking those and making the right side of the brain the more dominant part of the brain, it allows the individual to have their big picture take over and block out those severe memories, perhaps. And so a lot of psychiatrists are using this new technique and having great success, including Dr. Buck, who's Robert
Buck, yeah. Yes. One interesting thing is that neuro-optometry in general, that you all have talked about, started in the 80s with Dr. Bill Padula, but it was not as well known. And there's two people who should be thanked at getting it more well known. The first one is Clark Elliott, who's a Ph.D. that had written the book, The Ghost in My Brain. And that's about how neuro-optometric rehabilitation got his life back after a concussion. And he combined neuro-optometric rehabilitation with neurocognitive development by Donna Lee Marcus from her work, Designs for Strong Minds. And the second person is Babak Kateb, who is the host and the founder of the Brain Mapping Association. He is an extraordinary visionary, and he foresaw this kind of organization years ago. I've known him for over 10 years now, and he's a medical doctor who looked at what I wrote as a proposal for an optometry group, and he said the people editing it said, oh, this is nothing. And he said, no, this is a diamond in the rough. This is a profession that we need to put into our group. And because of his visionary ability, he has promoted neuro-optometry across many barriers that we would not have been able to get through, and linked up PhDs and MDs and neurosurgeons, neuroscientists, engineers from all over the world. He has done an unbelievable job with this organization.
So there's two other components of the Keep Smiling movement that we've observed and noticed. One is that people who are very confident, who seem to have abundance in their lives, seem to be the people who are most willing to be really silly and act out with their smiles. And so as we're doing, taking more pictures, I'm really interested in looking more of the research that comes along with that, with esteem, confidence, and how they feel about themselves biopsychophysically in the world with that. And the other part is, you know, we were talking, I used to work in law enforcement, so when you mentioned with the PTSD, with veterans, and with anybody who sees trauma or what's trauma to them, you know, that input of seeing that, when we think about, when we take that in and how that affects us internally with our, how that visual input and output, if we're putting out smiles and we're taking in more smiles, how does that affect us cross-culturally as well as anything that's with trauma? We have the cards in multiple different languages. I think there's 26 languages now and are looking for an app with multiple ones. So that way we can reach anybody at any language and where they're at in the world so that they can have that feel good in the moment and hopefully that long-term effect that I'm hoping that is happening with these kids who are struggling in school and with the PTSD, and certainly with someone with a brain disorder. Yeah.
It's funny, improvisational comedy does the same thing. When you smile or not smile, you're exuding an emotion, and other people pick up on that.
I think, you know, one thing that we need to realize with traumatic brain injury, I mean, we don't want to paint too much of a negative picture, but we need to sit back and realize that there is, in the traumatic brain injury population, if you're symptomatic enough to be labeled as a post-concussion syndrome patient, which usually happens after about 2 or 3 months, there's actually a 3 times higher rate of suicide in that population. So we often see patients coming into our offices, those of us who deal with these types of cases. I mean, I've added it as part of my questionnaire on my intake because I really want to have a frank conversation to make sure we're aware of that, and we have a neuropsychologist involved in the cases that need that. But I think the amount of times that we have heard these patients in neuro-optometric rehab say after they've come out on the other side. So I'm not talking about when they come into the clinic, because often they're very guarded about their symptoms. But on the other side, they're very open and say, oh yeah, I had lots of thoughts about that stuff coming into rehab. And I think, you know, vision is not the only part. There's hormone dysfunction, there is blood pressure, there is neuropsychology, there's speech pathology, there's neck and back. You were talking about posture and POTS, but the vagus nerve going through the SCM muscle. I mean, posture is a big thing in these patients. Most concussion patients, you'll often see a forward head posture where the SCM muscles will contract and pull the whole head forward. And we've all seen those pictures where it says, you know, if the head tilts forward by 2 or 3 degrees, it adds X amount of pounds to the weight of the head. So making sure that we're also paying attention to what's going on in the neck. But putting these teams together, I mean, in Guelph in Ontario, we have this group called the Sandbox. And we called it the Sandbox because we all learn how to play nicely in the sandbox. We all do our jobs well, but it's not about us and our egos, it's about the patients. And I think us going back to that and making sure that, yes, it is about the patient at the end of the day, and every case is different. But if we can get a patient out on the other side who's smiling, who hasn't smiled in 3 years, and is no longer having these thoughts of self-harm, because there's nothing worse than having an injury. How many of us have heard that concussion patient who says, I wish I had a cast around my head so other people could see I'm injured? It's a hidden injury. So these patients, if they go to doctor after doctor after doctor, and these doctors are saying there's nothing wrong with you, your MRI is clear, you're 20/20 on the eye chart, how long is it going to be before this significant other person or the people in that patient's family's life start to kind of doubt the patient? And when they're feeling doubted and they're struggling with their function, you know, if we think we're doing a really good job in these patients, then we need to explain why there's a 3 times higher rate of suicide in these patients. So I think we really need to start taking this interdisciplinary approach very seriously.
And that's what Clark Elliott's book, That Goes to My Brain, people come in all the time with that and they say, I'm so happy he wrote this book because this explains what I've been feeling. And the people coming in say, you know, I gave it to my family members and now they understand. It's at the Mind Eye Institute, that's what we're trying to do, is put together research based on the clinic experiences that these patients have and help. Because it's the neatest thing that optometry can do is start regulating the immune system and the neurological systems, because you're changing brain function. And I had a patient who is studying medicine, and I asked him what specialty he was interested in, and he said that to him the most challenging would be immunology and neurology, because all throughout life those things change and they're modifiable through neuroplasticity. And the immune system is different in old age as young age. It develops, it redevelops. Whereas he said orthopedic surgery, once you learn it, you know, you have wrists and knees and arms and elbows, but it's not as exciting. So the changes. And then there's other people who love the orthopedics because they like to do the one thing and get very, very good at it. So everything's needed. We're a melting pot of practitioners. Everybody needs a team of practitioners to fix them or to help them learn new skills. So optometry is just one of the many practitioners, but it's an important one because it deals with the environmental changes and how the body and the mind adapt to those changes.
Well, I'm really excited about the fact that, because you were saying, like, how do we get more exposure out there? And I'm like, yay, the Keep Smiling movement. If we can get that viral where people want to have their pictures with a Keep Smiling card. And our goal is to have 20 million cards out by 2020. So I'm like, which is funny that we'd already come up with the 2020 play on words as well for getting so much out. But if we could create that outreach with all of you, I mean, that would be such a blessing with us to partner with people to make a difference.
And get the stories out there, right?
Yeah.
I mean, like with my daughter after her concussion, after seeing a neuro-optometrist, and this is 10 months post-concussion, she's still having severe symptoms. Her migraines went away, her Alice in Wonderland went away. She's up to exercising 2 hours a day now. She's able to read and write, and she's back to being a high-achieving student, which we weren't sure what the long-term outcomes were going to be.
So what kind of student?
High-achieving student.
Oh, high-achieving.
She's a competitive kid. She loves school, and that was the hardest part of a concussion. Is she was only able to attend school 20 minutes a week, some weeks, and that was just for a little bit of socialization. So it is amazing. It's truly amazing.
And really, what if you guys had not brought those two specializations together, like with the mind-eye connection? I mean, that's why we met you, and that's the only reason that I'm here. And because of that connection, I just think of the outreach that you're causing with all of the different things that you guys are pulling together. It's amazing.
I met Andrea because of the Make a Difference movement.
Yeah.
And that's in Chicago. That's
Lynn Sanders.
and if Lynn Sanders hadn't have had her Make a Difference people, then I would never have met you.
Yeah, and if Barry Shore, the original gentleman who had the Keep Smiling card, hadn't become a quadriplegic overnight from an undiagnosed Guillain-Barré syndrome, we would have never been here. So it's interesting how unhealthiness has brought us together to create more healthiness.
I need to thank all of you for participating in a discussion on how the environment affects the inside of the body and how eyesight is definitely not just the 20/20, and how eyeglasses astoundingly can affect thyroid function, blood pressure. I'm giving a speech this June at a stroke convention on what eyeglasses can do to blood pressure. And it's amazing what the new research will be coming out with.
I think it's just amazing how many people eyeglasses can help. You know, it's concussion patients, it's patients with learning difficulties, it's patients who suffer from migraines. It's the more I read about it, the more fascinated I am with this
because
field.
of what Patrick says. Anybody with a brain.
So should anyone who's struggling to learn, should they have neuro-optometric clinics at schools, right? I mean, it can just help so many people. And so how do we push this field forward, and what can we all do to help promote it? Is
because
a question.
Brain assessment is a necessary tool at the school level.
Yeah, and I think one of the other important components that we have to look at is, you know, as a PhD, maybe I'm biased, I like the research standpoint, but also as a clinician, what I'm passionate about is trying to forge forward on clinically translational research. So making sure that the basic science and the research is able to be done, but also then to be translated back into the clinic, so we actually have an end result for people who are walking into our clinics with these types of issues. It's really, really important.
So thank you, Dr. Quaid. Thank you, Andrea Adams-Miller. Thank you, Shannon Mandel. Thank you, Robert Wilson.